So I'm recording to the cloud of the account.
Yes, record on cloud.
Thank you.
Thank you. So
I think about just under 3 minutes away from 1:15.
yes, so I'd like to welcome those that have joined in at this point. This is the Radiology Without Borders channel. We host our meetings every Thursdays at 7 or 7:15 Central African time. And our focus is ultrasound and medicine. So today we have a very special speaker. I'll let Sir Admire to formally introduce our speaker so that on the dot we'll begin our meeting. Sir Admire, please introduce our speaker for tonight.
Okay, thank you, David. So today we are honored to be having, I think everyone has been eagerly anticipating being graced by our fetal medicine specialist from Zimbabwe, Dr. Claudius Verenga, who will be taking us through the journey of, I think is a topic which some time back created some huge debates on the WhatsApp platforms. And I think today, after the presentation, I think we'll be at a better place academically, as well as clinically, because I think the ultimate aim of these initiatives is to equip us with the necessary skills and knowledge so that we can better serve our patients wherever we are across Africa. Africa has always been looked down upon, but I think it's our responsibility to upskill ourselves. And this platform is one of the avenues which actually has the mission and vision of empowering sonographers, radiographers, and all those involved in using ultrasound in Africa. So, as you are aware, Dr. Claudius Verenga is a fetal medicine specialist from under the tutelage of the great Professor Kypros Nicolaides of the Fetal Medicine Foundation UK. And he has a passion in teaching. You know, most people, after they finish specializing in fetal medicine, they usually prefer staying in the United Kingdom. But this man was selfless. He came back to Zimbabwe and set up our fetal medicine units at Mugabe and at Myometrium, Parirenyatwa. And he has been involved in teaching so that, you know, our level is at the world standard. And I think we are getting there bit by bit, and it's now going beyond Zimbabwe. Botswana is involved, Zambia, and South Africa has also been impacted. And now we are going for Africa. And today we have our audience from all over Africa. We've got radiographers and sonographers from Zambia, from Botswana, from Zimbabwe, South Africa. We've got Tanzania, we've got Nigeria. We also have, I think, the other countries. We've got, I think, Cuthbert, who is based in, is it Bangladesh, David?
Yes, it is Bangladesh.
Yes, he's based in Bangladesh. We also have Chileka. Chileka is in...
He's in Hong Kong.
Hong Kong. Yeah, so we have got quite a huge coverage, and I believe everyone will be a beneficiary of today's talk. I can see, I think it's now 17 past by my clock, and I would want to hand over to today's speaker. Over to you, Doc.
Thank you so much, Admire, for the eulogies. They are quite humbling. Thank you so much. Thank you. And I would like to express my gratitude to the Radiology Without Borders team for inviting me to speak. And I feel honored, to be honest, to be speaking to this wonderful group. Endometriosis, as you are aware, is one of the biggest gynecological headache. So what I've done is I've also shared the link with my gynecology colleagues to come into this meeting so that they can give an input. In particular, I've asked Dr. Dragana Djordjevic, who is a gyne endoscopy specialist who has done a lot of surgery in endometriosis. So I've asked her probably to give us also input from the surgical point of view, and so that she can comment, because she does a lot of endometriosis dissection laparoscopically. So I've invited her into this meeting. So to just start, Admire has already introduced me. And I want you to know that my passion is with fetal medicine. And the only reason why I started doing gynecology scan in 2015 is because I noted that women were not being scanned transvaginally in most of our centers. They were actually being done transabdominal scans. So I actually started doing gynecology scans so that I could teach people, or my colleagues and radiographers whom I would meet then, to say, look, guys, the best way to look at a non-pregnant uterus is transvaginally, not transabdominally. And what I'm going to share with you, I'm going to share with you some of our work, despite the fact that 95% of the work we do in ultrasound is to do with fetuses. We do get referral from our colleagues who want us to do transvaginal assessment of certain cases, both at the fetal medicine units and also in the private clinic. So I'll be showing some of our images from that work that we do, and some of the images I'll be sharing with you from the work done by some international groups from this presentation. So probably to start the presentation without wasting much time, I just thought I should address this question from the beginning. I've already told you that the biggest problem that we had in terms of gynecology scanning is that it is being done the wrong way. The wrong way is to scan women transabdominally alone. If they are going to be scanned both transabdominally and transvaginally, then that's better. But you can see for yourself the advantages of using both the transabdominal and the transvaginal approach. And this is what ESOG tells us or recommends, that gynecological ultrasonography is often better performed by the transvaginal route, transvaginally than transabdominal approach. This provides high resolution images. So this is the best way to do a gynecology scan, because I'm not going to be referring to any transabdominal images in my presentation, because in endometriosis, it is of very little value. In endometriosis, you would rather do transrectal if you cannot do transvaginal because the woman is vigo intacta, than to do transabdominal to try and evaluate a woman with endometriosis. So transvaginal is the way to go. I know that some centers in Africa, probably they do not even have a transvaginal probe, but this should be our aim, that we should be equipped to assess women transvaginal, because transabdominal, to be honest, is a very substandard way of trying to evaluate pelvic pathology in cases, especially of endometriosis. What is normal one of the biggest problems we have in gynecology scan is that there is poor standardization. A lot of work has been done in obstetric scan standardization, but in gynecology scan, there is a lot of non-standardization, so that different centers do things differently. As a result, it is very difficult to even compare studies that are done in gynecology ultrasound or pelvic ultrasound. But most international guidelines or international groups will quote the normal ranges for the uterus size as the ones I've put there, to say if you see that the uterus is greater than 10 centimeters, certainly that uterus is abnormally big. And if the width is beyond 5 centimeters or below 4 centimeters, all this is an abnormally big uterus. Then, of course, the echo texture, the uterus is supposed to be homogeneous initial echo texture. That means it's supposed to appear the same in terms of its echo density. It shouldn't have different colors or different appearance, different gray, black, and white scale appearance. It shouldn't be that. And the ovaries, these are sort of the reference ranges which are quoted in most texts. You say this is what you consider to be normal, and the volume is not supposed to exceed 10 mils when you do 3 orthogonal plane measurements of the ovaries, as you will see in some of my images. Then when it comes to andra follicles, we should see between 4 to 9 follicles. Excess of 10 is considered abnormal, and the andra follicles should measure between 2 to 10 millimeters for us to say, indeed, these are andra follicles, and the echo texture should be homogeneous of the ovaries. Then in terms of the endometrial thickness, of course, there is a nomogram, which I will show you, which depends on the woman's day of the last menstrual period. But roughly, for a woman who is just ovulated in pre-ovulated phase, just ovulated in the follicular phase, you expect them to have a thickness of between 3 to 5 millimeters and a slight hypoechogen, but this varies depending on the woman's menstrual period. And the uterinatal Dopplers, I know these are not commonly routinely done, but the guys who do fertility scans, they do this quite often, and we say pulsatility index should at least be less than 3 for the guys who do fertility scans. Then when it comes to endometriosis, what is the purpose of assessing doing a proper pelvic ultrasound scan? The main purpose is so that you can explain the underlying symptoms. Women who suffer from symptoms of endometriosis, they are women who really suffer, so that they need an explanation as to why they are suffering. They need somebody to tell them that at least you are suffering from A, B, C, D, than for people to just say, look, this is chronic pelvic pain without a synonym to it. So it is very important to realize that you have to explain the underlying symptoms to the woman, to say you are more likely to be suffering from endometriosis because of my ultrasound scan findings. The ultrasound also allows us to map the disease location, to say which part of the pelvis is affected worse than the other, and also to assess the disease severity. This is all trying to feed into the definitive management of the patient, which could be medical therapy or surgical intervention. I'm glad that my gynecology colleagues who manage these women are here in the meeting. Probably they will give us a comment at the end of how important it is. Most of my presentation on the evaluation is going to be based on the work done by this IDEA group here. This group has made a proposal of how we should be approaching women we are suspecting to have endometriosis, and they've also tried to define some of the terms and also the definitions and the measurements, and they've come up with a consensus. So it is the work of this group, which I will reference to. Some of the graphic images you will see will come from this paper by this group, which you can always find online and read for yourself. Then before you scan a woman who comes to you, this applies to everything. This does not apply only to endometriosis. We have a principle we should always teach our fellows and also our students who pass through fetal medicine that you do not scan a person you don't know, and hence you need to take a very detailed history of the patient before you even touch them, so that you know the kind or the type of scan that you have to do on the patient. So demographic history is very important. You need to know the patient, of course, the demographic data like the age, the height, the weight, ethnic origin, and the parity. Because sometimes the higher the parity, the more the risk of endometriosis. Then we need to know the bleeding pattern. Is it irregular, or absent? You need to know the last menstrual period. This is always very important because you could be dealing with a pregnancy, because it is very different for somebody who comes with pain and they are pregnant, and a woman who comes with pain and they are not pregnant. The differential diagnosis and the approach differs. Then you want to know the previous surgery for endometriosis, if they have the type of surgery done and the effect, whether they got a relief or not from the surgery. Then you want to know history of previous myomectomy or cesarean delivery. All these operations predispose to endometriosis, especially the deep infiltrative endometriosis in areas such as the bladder. Then we want to know the family history. There is a family history linkage to endometriosis, and we also want to know the previous non-surgical treatment for endometriosis, the type, duration, and the effect. And you want to know the subfertility, if there is subfertility, including the duration of this subfertility. You also want to know if there is pain, that is dysmenorrhea. Dysmenorrhea, that means pain during the menstrual cycle, and dyspareunia, that means pain during sexual intercourse, and dysuria is pain during urination, and dyschezia, pain during defecation. And you also want to know if there's any underlying history of chronic pelvic pain. You would also want to know if they are passing blood per stool or passing blood per urine. And you want to know the history of, I think I've mentioned subfertility and any treatment that the woman could have had for subfertility. Then for the clinical colleagues who may be in this meeting who do pelvic scans, it is important that a pelvic speculum examination be done so that you can have a direct visualization of the vagina or cervix. Sometimes you may see, appreciate some deep infiltrating endometriosis coming through the posterior fossas and so forth. If you do a direct speculum examination, and vaginal palpation is to be done to check for mobility and or fixation of the pelvic organs, and also the tenderness of both the uterus and the adnexal should be evaluated. And also site-specific tenderness should be evaluated, where the woman points to you and tell you, look, I'm feeling the pain in this area. Try to evaluate that area further, both through physical examination and then sonography. There is a group. This group, what they did is that they came up with a model that included history and symptoms of the woman to try and see the sensitivity or the specificity of using history and the woman's symptoms to try and predict if there is underlying deep infiltrative endometriosis. And they noted that history alone may give you a sensitivity of around 75% and a specificity of 70%. So history cannot be understated when you are scanning anyone, more so in the case of endometriosis. This is very important, especially for my radiography colleagues in the meeting. Please take 5 minutes of your time before you start the scan to try and get the woman's history. I am a medical doctor. I practice as a GP. I work as an obstetrician and a fetal medicine specialist. I can testify to you that doctors are very lazy to write on the request forms. So please don't just look at the request form and proceed with scanning the patient. Most of the information put on the request form does not specifically address the real problems in most cases, because doctors are very lazy. Okay, I am very lazy. Probably I used to be very lazy before I did fetal medicine in filling those request forms for ultrasound of the pelvis. So because of that, you have to check the history. It's very important. And what are the steps that you have to follow when you are evaluating the pelvis for endometriosis? First of all, do a routine evaluation of the uterus and adnexal, and look for sonographic signs of adenomyosis and the presence or absence of endometriomas. Then the step 2, you have to do evaluation of transvaginal sonographic soft markers. That is, you have to look for site-specific tenderness and ovarian mobility. I will try to show you how it is done on one of my images of my videos, how to try and sort of elicit these soft markers when you are doing a transvaginal scan. Then you also have to do an assessment of the status of partial Douglas using real-time ultrasound based sliding sign. There is a sliding sign which I will again try to explain during one of our short videos on transvaginal scan. Then we also, the next step is we want to assess for deep DIE means deep infiltrating endometriosis, nodules infiltrating endometriosis, that's DIE. So you want to assess for these DIE nodules in anterior and posterior compartment and also around the uterosacral ligaments. So I'll probably take you through each of these steps as we proceed. So let's just start with how do we do the transvaginal scan? Of course, in terms of how we do it, the woman has to be in lithotomy position or a modified lithotomy position. We encourage our women to empty the bladder. We know that the majority of women will not empty their bladder totally, which is to our advantage because we still need to assess the bladder mucosa. So we ask them to empty because a full bladder will make it difficult to distort and push the uterus posterior. So the woman has to empty the bladder when they are doing a TVS scan. So this is one of the reasons why we don't ask women to fill up their bladder until they are about to burst when they come for pelvic scan, because we always know that you can do TVS. That is one of the reasons why we don't ask them to fill their bladder until they are about to burst. Just a second, I want to play this video here. Don't know, let's see. What do I do here? All right, here we go. So this is a video to demonstrate the performance of a transvaginal scan, one of our videos. Then you put on the introiters. It's a direct visualization technique. I was too fast there, but this is a direct visualization technique. So you see there we are. We just arrived at the uterus. You can see, oh, don't know what I was doing there. There we are. So that's the fundus. You can see a nice endometrial canal there. And we continue to move as we see the endometrium and going sideways. I'm just going sideways, sweeping the probe from one side, turning 90 degrees now. The video, and okay, there's an ovary just lying over there, which we'll look at later. Then quickly, we're now going to the ovary. I'm sorry, the video is too fast. I wish I had slowed it down. So that's the ovary there. Let me replay it again. I don't know if I can make it slow. Yeah, here we go. So as we go in, it's a direct visualization. That means all you have to do, you put the probe on the introiters. The rest of the examination is done while you are looking at the scan. You want to identify the bladder, which in this case the bladder was totally empty, difficult to identify. But this is the place where you want to put the probe for you to visualize the uterus and the endometrial canal, the way we are doing it there. So we see here, so you can see very nicely the endometrium canal there and the fundus of the uterus. You can see that this uterus looks okay because it's homogeneous in appearance. Then we go there. There is the whole uterus, right? Then we turn 90 degrees to see the other part. Then we make a sweep from the fundus all the way to the cervix. Then we go to the adnexal region. Sorry, the video is too fast. To the adnexal region where we see the ovary there. Then once we see the ovary, of course, we have to go back and make some still images to do the measurements of these structures, as I would demonstrate on one of the images, how the measurements are done. So, so here we go all the way, then we see the ovary. Of course, we have to zoom on the ovary before we perform the measurement. You see the one which is measured. So that's the performance of the transvaginal scan. While we are performing the transvaginal scan, I'm sorry to say I don't have a video to show the sliding side, but I'm going to demonstrate it on this image here. So what you do with the sliding sign is that using this probe, we'll come here to the cervix and we'll push the uterus with the probe to see if the uterus is sliding freely at the back here. And also we'll put our other hand, as demonstrated on the image by that group, which I showed you, to see if there's free movement around the bowels at the fundal area. So we want to test the back side of the uterus to see if one is sliding nicely around the rectal and also the peritoneal, the rectum, and also the peritoneal area, and also with the bowels. So we want to see if there's free movement of the uterus there. That is what you call a sliding sign, and this is what you do for an anteverted uterus. For a retroverted uterus, we have to put our probe right at the back, because a retroverted uterus is looking the opposite. Then we do the same pushing to see if there's free glide of the uterus on the peritoneum, and we'll do the same again to check if there's free glide of the uterus on the bowel. So if there's free movement, then in that case we say the slide sign is positive. Positive, that means everything is normal. But if there is no movement and it is stuck, then we know that it is negative, and this will suggest that there are now adhesions between the uterus back and the rectal walls here. And the same will apply to the bowel, to the fundus. If you cannot freely move the fundus with one of your hands, what it means that there are now adhesions between the uterus and the bowel. And in a woman who, from their history, suggests that there is endometriosis, then your diagnosis is actually strengthened by this finding. Then we also need to assess the pouch of Douglas. The pouch of Douglas is always easy to see, to assess nicely when there's some fluid. Of course, there is physiological fluid, which is normally less than 10 millimeters in depth, but you always have to correlate with the patient's history to say, is this normal or is this abnormal? But this is how you do the measurement. There's fluid. But when we are doing the sliding sign, we are assessing if there's free glide between these walls that we can see. At the upper part there, that will be the rectal wall, and also the upper vagina wall, and also the back of the uterus. This is what we'll be checking when we are doing the sliding sign, looking for evidence of adhesion. And this is the area also we also check, as you see in the preceding slides, we check for endometriotic nodules. The bladder also has to be assessed. I'll show you again another video of ours there. So you can see this is a partially filled bladder. It allows us to assess the mucosa to make sure that the mucosa is as smooth as it should be, and that there are no nodules, endometriotic nodules protruding into the bladder. There is the bladder wall. This is all done transvaginally, and we can also evaluate the cervix using the same method. Instead of going all the way, we just stay at the cervix and we make sweeps, as you see on the video playing. Yeah, just making some sweeps. Yeah, just some sweeps on the cervical area, just checking the cervix there. Sometimes you may have these cervical nodules, so the cervix also has to be evaluated. Let's go a little bit deeper into evaluating the uterus. So the uterus anatomically, this is an image again from that same group, the graphical image. This is one of our images. The ultrasound scan image is one of our images from fetal clinic. So we can see this is the endometrial cavity, which in most cases, it is just a line because there is nothing. If there is nothing, it's always a line in between the endometrium walls. So in this image, it is just a line. It is represented by just a very thin line, the uterine cavity or the endometrial cavity there. Then we will see the endometrium here. And this is the endometrium we see, which is slightly brighter compared to the other parts of the uterus. Then we have what we call the inner myometrium. The inner myometrium is in this image. Of course, you have to imagine a little bit, but the inner myometrium is just this wall layer just outside the endometrial cavity. Then we have the middle myometrium, and then we have the serosa, and there is a vascular cascade somewhere, which if we put the color Doppler, we will be able to see this vascular cascade. And when we are assessing the uterus, as I have already said, that you need to make these sweeps while in sagittal plane with the transvaginal probe, to make the sweeps from right to left, to make sure that indeed the myometrium is homogeneous in echo texture. And you also need to turn the probe 90 degrees so that you can make the sweeps from the fundus all the way to the cervix. Make sure that you are not missing any lateral uterine wall pathology. So the uterus has to be assessed this way, and the endometrium, when you are assessing it, we have to make sure that the endometrium myometrial junction is well demarcated and is clear, and there is a clear distinction between the inner myometrial wall and the endometrium canal. This distinction has to be clear. If we cannot properly see the endometrium canal, then there is a problem. This is very important, especially in the context of endometriosis pathology, in the context of adenomyosis. So the endometrial myometrial junction has to be clear. If you cannot see it, there is a problem. Don't say it is normal. I've already told you that the endometrium varies with the cycle, but what you know is that the 99th centile, or a value which will always be abnormal, is if you get a value of 10 millimeters, there is no way it can be normal for any given day of the last normal menstrual period. And when we are measuring the endometrium canal, what is recommended by most international groups is that you should measure the endometrium thickness with the uterus in the sagittal plane, so that you measure the thickest part of the endometrium. Don't do it in the transverse plane, because in the transverse plane it's very difficult to know which part of the uterus is the thickest, or the endometrium is the thickest, when you're in the transverse plane of the uterus. So this is the recommended way. So you look for the thickest part, then you do your transverse measurement of the endometrial thickness. Then you can comment depending on the way that is within normal or it is abnormally thick. The pathogenesis of adenomyosis, of course, there is a lot of debate. Adenomyosis, in terms of the prevalence and the incidence, it is not known internationally how common this pathology is. One, because of the different nomenclature, and there is no standardization that it was being applied by many people who scan. So there is paucity of international data for us to be able to say how common is this pathology. But what we know is that this pathology is there. The question now is, what causes it? There are many theories, but the theory that most people probably talk about is to say there is an abnormal invasion of the endometrium cells into the myometrium, which can just occur due to inflammatory factors, or it can occur due to previous surgery. This is why the history of previous surgery is very important when you are asking the woman's history. So this is these are some of the sort of the features that make people believe that probably there could be a theory to say there is abnormal invasion of the endometrium cells into the myometrium. So there is these subendometrial lines you may see in women with endometriosis. These are just very thin lines that you may see as demonstrated by that group which I already introduced, that you could see some of these, and sometimes you could see this echoic area with cystic areas inside, and you can see some subendometrial buds is illustrated there and is shown there. Remember, we said when you are analyzing the endometrium myometrial junction, it should be very smooth and well demarcated. But if you begin to see this irregular endometrial myometrial junction, then you need to begin to think and say, is something going on, especially in the context of a history that suggests endometriosis. Then sometimes you may see hyperechogenic islands, which are demonstrated here. You can only see this kind of pathology at the transvaginal scan. Of course, with a machine with a very good screen resolution. You are not going to see this with transabdominal. This is why I said I'm not going to be talking about transabdominal scan, because it's not going to add any value in terms of this kind of analysis of endometrial tissue. So these are some of the findings on ultrasound that convince people that, look, probably it's more of this kind of pathogenesis, which holds water in terms of saying, how does it come about? So you may come into encounter with this kind of pathologies as we evaluate the endometrial myometrial junction. It should always be evaluated in women with this kind of symptoms. In terms of the histology of adenomyosis, unfortunately, again, there is no consensus amongst histologists globally. But when you send after doing a hysterectomy, as well for my gynecologist colleagues, after doing a hysterectomy, you may get a report with any of these statements that I've put there. Sometimes they may write that there is a disruption of the normal boundary between the endometrial and myometrial. So that means the endometrial myometrial junction is disrupted. Sometimes you may get an ectopic endometrium in basal type non-secretory tissue with a direct connection to the basalis layer. Or you may have myometrial invasion of the endometrium of greater than 4 millimeters below the basalis layer, or myometrial invasion of endometrium of greater than 2.5 millimeters below the basal layer, or greater than 25% of the thickness of the uterine musculature as measured from the endometrial myometrial junction is invaded by endometrium tissue. So you may get this kind of histological reports, because there is again no consensus. Then in terms of classification, endometriosis can be classified into focal or diffuse, or you might have what you call adenomyomas, which sort of mimic fibroids. If you don't look carefully, you may think, because they are well circumscribed adenomyoma lesions that you may see, that you may mistake for fibroids. Then when it comes to focalized, this could be classified into those which are greater than 25% in terms of visibility of normal sort of myometrium around it, or we could have a 100% situation around the focal lesion. All these types, we have to look at the uterus carefully to be able to distinguish these three types between the focal, the diffuse, which is just evenly sparse, and also the adenomyomas. We could also classify them into cystic and non-cystic. Cystic, that means you are going to be seeing small cysts within the adenomyomas or within the adenomyoma tissue. And these cysts have to measure more than 2 millimeters for it to classify as a cystic adenomyoma lesion. And then in terms of the infiltration type, you may see this junctional zone type, which infiltrate at the level of the endometrium myometrial junction. That is where they are closely located. And you may see also the middle myometrial, which are between the inner myometrium and the vascular ring, which I've already mentioned. And you may see the outer myometrium, which is type 3. So they may be classified into type 1, type 2, and type 3. Then the International Morphology of Morphological Uterus Sonographic Assessment Group, they have come up with this criteria for adenomyosis, where they say if you see these kind of features when you are doing ultrasound, you need to think of adenomyosis. If you see a globular uterus, I've already shown you what a normal uterus looks like. So if you see that you are looking at this uterus, which looks globular, you need to think of adenomyosis. Adenomyosis means especially in our country in Zimbabwe, is missed quite often because most women are examined transabdominally. So the detail of this globular and so forth may be missed because of the poor resolution of the transabdominal approach when looking at the uterus. So if you see this kind of a globular, I will show you some of our images of what this looks like. Then if you see asymmetric thickening of the uterus, you see that the anterior and the posterior uterine wall are of different thickness. Then you need to suspect adenomyosis. The normal uterus should have almost an equal anterior and posterior myometrial wall. If you see cysts within the myometrium, that is abnormal again, we said the myometrium should have homogeneous echogenicity. Then if you see hyperechoic islands, or you see fan-shaped shadowing, on the, but sometimes we call it shadow speculations. If you see these ones as well, you know that you are likely to be dealing with endometriosis. And if you see echogenic subendometrial lines and bars and translesional vascularity, that is, if you put on the color at the level of the uterus and see these vascular vessels on the uterus, you may be dealing with endometriosis. Irregular junctional zone, that means the endometrial myometrial junction is very irregular or obliterated or interrupted. You may not see the endometrial myometrial junction as you see on the image to come, or you may see this interrupted endometrial myometrial junction. So all these features are pointing towards endometriosis, adenomyosis at the level of the uterus. So let's go through some of our images. This is one of our patients again. They came and all we saw was this. At first we asked them, so far we deal with the fibroid, not convincing. The fibroid doesn't just give you this increased echogenicity and what looks like cystic areas in it, and the boundary is poorly demarcated there. So this lady will give a diagnosis of endometriosis. It was more of a focal endometriosis close to the junctional zone. That is the diagnosis we gave this woman. Of course, we had to correlate with the symptoms, but we said this is more likely an endometriosis, an adenomyosis lesion within the myometrium. Then we do have this uterus as well. We suspected adenomyosis. One of the reasons why we suspect adenomyosis is when you looked at the uterus, you can see that the this myometrium looks a little bit thicker. The anterior myometrium looks way, way thicker than the posterior myometrium. And we're not very happy with the way the endometrial myometrial junction looked. It didn't look as clean as we would want it to. So we again gave a possible diagnosis of adenomyosis, and also this increased echogenic areas around this area made us suspect the diagnosis of adenomyosis for this uterus. This is again to just illustrate you the measurements. In this case, the endometrium was enlarged, but if you compare the measurements of the anterior and posterior uterine wall, you can see that there is a big difference there in the measurement. Probably I could have come through there, but there is a big measurement, a big discrepancy between the anterior and myometrial, posterior myometrial wall when we are measuring from the endometrial myometrial junction. Again, we gave this woman a possible diagnosis of adenomyosis. Then we have this lady who came again with symptoms. And if you look at the uterus, this is what we mean by globular shape. So you can see it's a globular shaped, looking like a globe. If you look at this uterus here, so this is what we mean by globular shape. And look at the echo texture. this is not homogeneous at all. And if you try to follow the endometrium canal all the way from the cervical canal there, you can see that it is obliterated some parts, and we cannot clearly distinguish the endometrial myometrial junction. So we gave this one again a diagnosis of adenomyosis because of the ultrasound scan features we got there. And you can see there is a lot of shadowing. It's impossible to see what is at the back here. This is again another case where, again, symptoms. If you look again carefully, you see that the endometrial myometrial junction is well demarcated. It's not what you saw in the other images. It's certainly different there. It's not clear-cut, the endometrial myometrial junction. So again, this we suspected a diagnosis of endometriosis, and the way the uterus is shaping, trying to be globular there. So this was again a suspected case of adenomyosis. To demonstrate again, look at this case, look at the echo texture of the uterus that is not purely homogeneous. You can see that there is more of hypo echoic texture we see there, which is common with adenomyosis because there is hyper increased vascularization in adenomyosis. So we can see again the endometrial myometrial junction that is not well demarcated. It's an irregular endometrium myometrial junction. Again, we suspected and we measured the anterior and the posterior wall. Look at this measurement that there is a difference between the posterior, and you can see some hypoechoic lesions there. So again, this was a case of suspected adenomyosis. So from the same group which I said, when you now want to report on the adenomyosis, there are certain components which should be in your report. What are those? You should state the presence of a myometrial abnormality based on the Musa criteria, the one which I have already showed you, and also the location of the adenomyosis, the differentiation between focal and the diffuse disease, and the discrimination between cystic and non-cystic lesions should be done. And you should have a myometrial layer involvement, the layer which is involved in the myometrial, whether that is the middle, the inner, or the outer myometrial layer. Then the disease can be classified as mild, moderate, or severe, depending on the extent of involvement of the uterus. If it's less than 25%, mild disease, more than 25 to 50, between 25 and 50 is moderate, and greater than 50% is severe. Then the size of lesion should also be measured in 3 orthogonal planes. And these are the kind of description that can come out of doing all that. You can end up with the focal type, which is 1 to 2. This is a cystic adenomyosis in the anterior wall, which with mild diameter of, which is mild with a diameter of 2 centimeters. So these are the kind of descriptions that can come out of a combination of all the features which I described in terms of the actual description of the adenomyosis. So you can have the diffuse type 1-3, diffuse type 1-2, the mixed type cystic adenomyosis type 1-2. You can also have the mixed type cystic adenomyosis type 2. I think for the sake of time, I will not read through this. You can always access this on the from the Radiology Society video library, right? Then the next stage is to assess the ovaries. We spoke about assessing the adnexals. Just a quick video to say how do you access the adnexal. You can see an ovary. This is all transvaginal. We have just turned 90 degrees the probe there. We can see some nice cysts in the ovary. Probably these ones are a little bit too many. Probably polycystic ovary there. So let's start again. In one plane, we turn 90 degrees to look, and then we make a sweep so that we go through the whole ovary, looking at the number of follicles, the type of the follicles, and also the the tissue of the ovary, how it appears. You can also use color. Sometimes you may struggle to locate the ovary, especially in women who have just eaten some few hours ago. Because of bowel, you may struggle. You may want to put color so that you locate the ovarian fossa, which is bordered by the iliac vessels, so that you see the ovary properly. So that's the transvaginal assessment of the ovary. And when you are measuring the ovary, this is how you do it. From the sagittal plane, you can obtain the height and also the length of the ovary when the transvaginal probe is in the sagittal plane. Then when you turn it 90 degrees, you can obtain the width of the ovary. And of course, you have to note if it is a physiological cyst and so forth. So the woman's history is in relationship to the menstrual period is very important. So this is how the ovaries have to be measured and to be looked at. And at the ovaries, we again do the sliding sign. We have to push on these ovaries and see if the ovary is moving freely around the other structures which are around the ovarian fossa. So the ovary has to be gently pushed with the probe to see if it is freely sliding around the other structures. This is very important. It's also part of the sliding sign to make sure that the ovary is not fixated, is not matted around the other organs, which occurs in deep infiltrative endometriosis. When you are describing adnexal pathology, we should always remember that there is this group here, the aorta group. The aorta group, they were doing studies where they were trying to come up with a consensus, because again, like we said, that in pelvic ultrasound, they lack consensus. People report differently. And because of that, it's very difficult to compare the data from one center to another. So this group tried to come up with sort of a consensus opinion in terms of the definition of the terms, the morphological characterization of the adnexal masses. And this is what they have proposed. First of all, they defined a lesion. They said a lesion is any cystic area which is not on the ovary, which is on the ovary, but which is not physiological. So if you see a cyst which doesn't look physiological and it's on the ovary, that is a lesion. And that lesion has to be measured separate from the ovary. Or if you cannot separate the lesion from the ovary at all, then the whole mass will become the lesion. Or you could have a situation whereby the ovary is free and nice, but you could still have an adnexal cyst, which could come from the fallopian tubes or from the fimbrial cyst. You could still have a lesion separate from the ovary, but the lesion has to be defined and say what is a lesion. So that means this therefore means that Graafian follicles are not lesions, neither are corpus luteum cyst lesions. Then in terms of morphological features, they suggested that when you are looking at these lesions, you could have what we call a cystic lesion, where it is all anechoic lesion. There is no solid components on it. And we should also mention the inner wall to say, is it a smooth one or is it an irregular inner wall when you are looking at the lesions? Then also you could have a solid lesion where it is all purely solid, the mass is solid, and in that case you have to describe it as solid. And you could have septars within the lesions where there is division within the lesions. They could be complete, or you could have incomplete septums, or you could have a situation where you have a solid cystic mass that is both solid and cystic component mixed within a mass. They also mentioned that you could have some papillary projections where you have some tissue projecting into the cystic mass, and these have to be measured or evaluated carefully. And you could have a multilocular cyst. A multilocular cyst, that means you have multiple cysts within a lesion, as you can see on this image here. This is the proposal to say, when you are describing a lesion, you rather use this kind of terms so that everybody will read the report, whether it is read in the streets of New York or in the streets of Tokyo, everybody knows what you are talking about. So it is very important to be aware of this way of reporting about lesions that we see in the adnexal. Just to illustrate what we mean, here you can see that this is ovarian tissue, but on the ovary there is this lesion which doesn't look physiological. So there was a lesion here, which is a unilocular lesion with probably regular inner walls. Maybe it could be irregular there, but largely irregular inner walls. So this is an example of a lesion as described by the IOTA group. The ovary tissue is here. It is measured separately, but we have a lesion which is attached to the ovary. Then you could have a situation where you have multiple these antral follicle cysts, because they are exceeding in number, then it becomes abnormal and it becomes a polycystic kidney, as you can see on this ovary, which is shown in two dimensions there, that they are multiple cysts which are surrounded. Then you could also have a multilocular cyst where you have these septations, and this septation can vary in thickness and they have to be measured, this thickness, but you can see there are multiple locals or multiple cystic areas there. And you can also see in this other image as well that there is a thick septum dividing these two cysts. So this is an example of multilocular cysts. This is more of a solid cystic mass. This is all solid adnexal mass with some cystic areas in there. This is just an example of what the IOTA was talking about. Then we have one of our patients who came to us with symptoms where we suspect that this woman had an endometrioma. Why did we think of an endometrioma? Because we looked at the wall of this cyst, and of course the contents are a little bit look like a hemorrhagic with strands inside them and a very thick wall there. So this is a case of an endometrioma from one of our ladies. After evaluating the adnexal and the uterus, we need to evaluate the anterior compartment. What is the anterior compartment? According to the same group which I've already presented, anterior compartment is this area which is made up of the bladder and the urethra, the trigone, the bladder base, and the bladder dome. The bladder dome is this area which is intra-abdominal, and there is this extra abdominal area. The endometric nodules tend to favor the bladder base and also the bladder dome. So this area has to be evaluated using ultrasound scan, using the sliding sign, and also careful zooming and zooming around this area, looking for nodules. So the bladder has to be evaluated. That means in the context of endometriosis, you don't want the bladder to be totally empty, so that you can examine the bladder mucosa to look for nodules. And also the uterovesical region has to be evaluated as well. And the ureters. The ureters are extremely difficult to evaluate, but people with experience in doing this work, they can evaluate the area, the ureters up to their level of entry into the bladder. It is possible to do it. So you may be able to identify some bladder-based nodules or some bladder dome nodules, and also some nodules on the ureter in very experienced hands. We do not have experience in doing this, to be honest, but this is possible as reported by that group. Then you can also check for uterovesical obliteration. This is easy. It is through the sliding sign that you push to see if there's free glide at the anterior wall there between the bladder and the uterus. Then as for the posterior compartment is this area which is bordered by the upper vagina, the cervix, uterus, and also the rectum, and we have the peritoneum there. And we want to examine the retrovaginal septum, the vaginal wall, and the retrovaginal nodule and look for retrovaginal nodules, and also the nodules on the rectum, rectosigmoid junction, and the sigmoid, and the uterosacral ligaments. They all have to be evaluated. I'll show you some images of these nodules that we have a rectovaginal septum nodule there, and sometimes it may affect just the septum alone, and also a vaginal wall nodule, rectal nodule, and a vaginal and rectum nodule, combining the two. We can also have a posterior vaginal fornix nodule. This is one of the reasons why a speculum examination is important. Sometimes these nodules can be visible with the naked eye through a speculum examination. Then a diapole-like nodules, which is going all the way to the back there, and also the uterosacral ligament nodules have to be assessed. To just give you an idea of what some of these nodules look like, if we look at the posterior vaginal wall nodule, this is an example of one of them. I admit that it may be extremely difficult to see this in inexperienced hands, but with experienced hands, people may reach this level of competence to be able to see this kind of nodules. Then we have a bowel wall nodule there, which we are seeing there with the measurements done by the same group which I mentioned. So this is how it looks, the nodule in the bowel wall from deep infiltrative endometriosis. Then we have, again, another nodule on the bowel. This is the bowel, the rectum part there. So that's the nodule, the two nodules which are illustrated by the measurement there. As a conclusion, I think the best way forward, first of all, I'm not sure about other African countries, how common is transvaginal scan, but in my country, it's not widely being done or widely available. The first step before to, I don't know, I think there's somebody unmuted. The best way to make progress is to, sorry, I'll just mute the participant which mic is making the noise. Sorry about this. Sorry. Okay, I'm failing to mute this participant. Okay, let me continue. So I think the best approach at the moment is to adopt the transvaginal scan as the primary method of evaluating pelvic pathology. It is not widely available in most of our centers, but we need to start from there because you cannot.
Sorry, Dr. Verenga.
Yes. I want to try and mute these colleagues who are with mics. How can I do it? I'm failing to unmute them, to mute them, sorry. I'm failing to mute these colleagues whose mics are on. Right, so first of all, we need to adopt transvaginal scan because at the moment it's partially being done and people who are doing it in some of the centers, they are making something so special and something like out of this world, but you cannot move out of these borders and go to progressive nations and present your work on pelvic ultrasound with transabdominal images. People will look at you and they'll think you've come from the past. You have time traveled kind of story. It is unheard of to say you are assessing pelvic pathology with the transabdominal scan alone in non-vigo intact women. So first of all, as Africa, we need to embrace transvaginal scans. Then we need also embrace the same nomenclature in describing pelvic pathology. In my country, each ultrasound scan unit is reporting its own way, so that it is very difficult to compare the scan findings because everybody is using their own term when they are describing what they've seen. So we need to bring uniformity into how we describe the pelvic pathology. I suggest that we follow what the Musa and the IOTA group have suggested. Then we need to create centers for training in transvaginal scan assessment of pelvic pathology. I live in a country where the School of Radiography and Sonography do not offer a course in transvaginal scan assessment. So we need to change that. Of course, in the fetal medicine unit, all our work, all our staff can now do transvaginal assessment of pregnancy. And we have also opened early pregnancy assessment units. And we have opened one at Sale and another one at Pari, where only transvaginal scan assessment is being done for gynecological emergency as a way of trying to promote and also train health workers on how to do a transvaginal assessment, because that's the correct thing to do. So I want to encourage centers that do not have that facility yet, and also training schools that are represented here, that it is now archaic and backward to continue to teach people how to do pelvic scan using the transabdominal approach alone. It is way, way archaic. This has to be taught not only in theory, but also in practice. Thank you so much. And as a way of finishing, I just want to show you this thing. This is the last of my presentation. I want to show you this, that we are organizing a fetal medicine congress for East, Central, and Southern Africa for the 28th of August. And these are the topics which I want to encourage some of you to submit your abstracts so that you could probably present, and you could share the stage with these icons in fetal medicine. We have Professor Kypros Nicolaides, who is the world leader in fetal medicine, Professor Amos Nicolau from South Africa, who is a leader in South Africa, then Professor Chauke. They will all be there to present with a lot of other colleagues from around the globe, but we want African presenters to be dominant in this meeting, because this is an African meeting to talk about women and fetal health in Africa. Thank you so much, and I want to thank the wonderful team I work with, who make it possible for us to produce these images, and also the team at FMF Zim, who make sure that our library of images continuously being updated for us to get the images to use. Thank you so much for the time, and I'll hand over time to the chair, and probably the chair, if you would allow my colleague Dr. Dragana to comment. She's a specialist in surgical operation of endometriosis. Thank you.
All right. Thank you so much. Thank you so much, Dr. Verenga, for such a wonderful presentation. It's one of those which you wish shouldn't come to an end, but unfortunately, it had to come to an end so that we can accommodate some questions, comments, and I think, Dr. Dragana, I think the floor is yours. You can come through and make your contributions.
Dear colleagues, I'm honored to be invited to such a distinguished meeting to give my comment. And thank you very much, Dr. Verenga, for this presentation. It is a revolutionary event and development in our setting. Our specialists, radiologists, ultrasound specialists, sonographists have moved on with the time, and I'm very proud of all of them. And they have actively started scanning patients with transvaginal probe. I have noticed that in several institutions, in particular after return of Dr. Verenga from UK. The reason for that being is that he has already trained the second generation of specialists who are actively using transvaginal probe. That has changed our work map, as we can prepare patients for surgery accurately, and we can obtain consent and explain the type of the surgery we are going to conduct on the patient. So if we are to take the patient to the theater and tell them we are going to do laparoscopic resection of endometriosis, we have to bear in mind that the importance is enormous of obtaining consent, because we might involve speciality like a rectal, colorectal surgeon, urologist, even thoracic surgeon. Recently I had to call for the pleural endometriotic nodules. So our current situation in Zimbabwe is that we can accurately, with the help of 3D transvaginal probe, we can identify adenomyosis, we can accurately spot bladder endonodules, Rectovaginal septum nodule is easily found. Endometriomas are easily identified, but we are indeed, I fully agree with Dr. Verenga, struggling with uterosacral ligament nodules and ureteric endometriosis unless there is a hydronephrosis present. What does this all presentation mean for us? If I translate this presentation to you, to our surgical experience, this is how it would look like preparation for the patient that we diagnosed, Dr. Verenga diagnosed with deep infiltrating endometriosis. And he said there is a large rectovaginal septum nodule, and the nodule is infiltrating rectum up to 4 millimeters in depth, and the lesion is somewhere 5 centimeters away from the anus. That means that we need a skilled, we will do it laparoscopically, but we will need a skilled rectal surgeon, colorectal surgeon who could do a discoidal resection. Deep infiltrating endometriosis of ureteric nodule would mean that we will prepare that patient and counsel the patient that we will potentially need to do a ureterolysis, assess the nodule, and if it's obliterating more than 25% of the ureter, we will have to do a excision of the nodule and ureteric anastomosis. If they've diagnosed the patient, or if we diagnose the patient with bladder endometriotic nodule, that means that we will possibly involve a urologist, particularly if it's close to trigonum, whereby we will have to open the bladder laparoscopically, excise the nodule, take it out, and leave the stent. Adenomyosis patient, particularly with a cystic adenomyosis, could be done laparoscopically if the nodules are not more than 4, and if the measurements are not more than 4 centimeters in diameter, with a strict explanation that the complete excision cannot be guaranteed like what we can guarantee with the fibroma, myoma. So it does make clearly huge difference when you're counseling the patient. And if you put yourself in the shoes of that patient, you will understand how different is, let us just put a little scope and we have just a little look, or we just put a scope and then we resect a bit of your rectum, or we just put a scope and we resect your bladder and leave the catheter for 10 days, and so on and so forth. On recent International Society of Gynecologist meeting a month ago, there were 2 wonderful presentations and research is presented. Tina Tellum from Norway and the lady Alexandra Di Giovanni, who works in the Center for Endometriosis in Italy. It was a multi-center study. They presented a breakthrough in preoperative diagnosis of endometriosis, where they proved that specificity and sensitivity of 3D transvaginal scan is 84% in comparison to MRI, which is 88%. So what does this mean? That we actually do not need to send our patients for $2,000 MRI. That's the current cost in Zimbabwe for the cash patients. But we can actually just use our 3D transvaginal probe and apply it as Dr. Verenga explained. And if we cannot see transvaginally, we can use a transrectal application and see where we are without spending all that money. It is, I think this presentation, once again, I'm repeating, is a breakthrough because it proves your importance as specialists, radiologists, ultrasonographists in pre-surgical evaluation of this devastating disease, which I have to say we see more and more in our settings. I thank you, Dr. Verenga, and I thank this wonderful audience.
Thank you so much, Dr. Dragana, for those insights. I think we can now entertain some questions. I can see the hand up. You can unmute your mic and ask your question. You can unmute the mic. Yes.
I think
please.
Chitumba has a question.
Yes, Mr. Chitumba, can proceed. Is he online?
I suspect that he could be, maybe the mic is still on mute, but there's a question from the chat, maybe that I could pose to Dr. Verenga, from Mr. Mingochi, who asked, what are the contraindications against the use of the transvaginal probe?
Thank you so much for the question. I think the only two which I know of is a woman who is vigo intacta and a woman who declines verbal consent. The woman who declines verbal consent and the woman who is vigo intacta. I think those are the two main contraindications to, or women who probably may experience severe discomfort during the procedure and we have to abandon it. I think that, but if there are colleagues who know other, they are more than welcome to also chip in. And let me also come in and say the acceptance rate. We will share with you our results of the acceptance of the transvaginal scan at this Congress, but the acceptance rate is very high, probably more than 80% from our own work, especially from the fetal medicine point of view, because we do transvaginal assessment of the cervix and also for other antenatal emergencies. So the acceptance rate is very good. One of the questions I was asked, especially in 2015, when I went to the radiology department in Paris, I hope he's Mr. Mr. Kasam, maybe he's in the meeting. I don't know if you remember the conversation. When I wanted to do transvaginal scan, first of all, they said we do not do transvaginal scans here because African women do not, it's culturally unacceptable. This is what I was told. That it's culturally unacceptable in Africa to do the transvaginal scan. But to be honest with you, from our own work, women, we have not met resistance from women, and none of the women have raised any cultural connotation to the performance of transvaginal scans so far from our own work.
Okay. Thank you for that. I think you have been answered. The one was asking, I can see their hands up. You can just unmute your mic and ask your question.
I think we have Chitumba's hand, then Mushosho, Dr. Dragana, and Paul Makondo. So I think, Chitumba, if you could quickly pause yours, then. Okay, just hold on, Paul. There were hands that were up before yours. You still come in. Let's have Chitumba. If Chitumba is not available, there is Mushosho.
Okay, good evening. Thank you very much, Dr. Verenga, for the excellent presentation. My question is, what's your take on the use of transperineal scanning in cases where transvaginal is contraindicated, or in cases where you can't do visual inspection of the vagina for you to see the lower third of the vagina?
Thank you so much, Ms. Mishosho, for the question. Let me say we do not have a lot of experience with the transperineal scan when it comes to pelvic scan, but we have some experience transperineal scan in intravaginal scanning for women who are in labor. That is where we have found its main role. So I do not have an answer to that, to be honest, because we don't have experience with that in pelvic scanning non-pregnant women. But in women who are in labor, yes, we have seen the benefit of it, that we have managed to obtain some answers where it is now impossible to see from the suprapubic area.
Okay, probably it's an area we need as sonographers and as probably fetal medicine, since you are bringing new things, probably we need to explore a bit more. I mean, I'm talking from a personal experience where a patient had examination using transvaginal and also transabdominal, but there was almost like an abscess in the lower vagina. And thank you so much for mentioning about taking history, because it's only after the history that I then suggested to do transperineal, and boom, I could see the abscess. But this person probably, I don't know the experience of the people who did the transvaginal, they missed that abscess, which was in the lower third of the vagina.
Okay. Yeah, thank you so much. Very interesting case there.
Thank you. We can have the next question. You can just unmute your mic.
I think Dr. Dragana's hand was up. Then Paul was the fourth.
I just wanted to comment on that contraindication for transvaginal scan. We truly, I can't remember when someone declined last time. I actually, this day and age, I don't see any difficulties through different religions, through different nations, through so many different groups of women that I see in our settings. No one is absolutely declining transvaginal scan. But we do have patients with a history of severe dyspareunia and transvaginal nodules, particularly posterior to the cervix. I visualized nodules. Those patients are struggling with transvaginal probe. And I fully agree, maybe we should not insist on transvaginal scanning in those cases. If you see that patient is in pain, then we can switch to the rectal scan and potentially apply some local anesthetic if you need to evaluate that nodule deeply.
Oh, thank you. In the chat, there is a question, or there's a contribution which is saying on one of the contraindications for transvaginal is saying infection. If there is, for example, cephalitis, so that you don't push the infection up. Then another, I don't know if you have a comment or you can just combine it with another question, which was asking if you ever come across juvenile adenomyosis in nulliparous young females who never had any surgeries. And a follow-up question to that, how prevalent are such cases?
Probably I'll push this on to Dr. Dragana to answer it.
Just the first question with cervicitis, that was the question about infection, vaginal infection, PV infection and cervicitis. I have to remind you that vagina is 24/7 communicating with a peritoneal cavity, isn't it? Through the cervix, through the endometrial cavity, and then through the tubes. So there is a continuous communication. So by bringing of transvaginal probe, you're not going to push that infection further more than any sexual intercourse or natural communication of the peritoneal cavity with the cervix. So with a proper use of transvaginal probe cover, or in our setting mostly condom, you stand a very good chance to scan that woman nicely. Again, I have to underline, as long as she's not in pain. So you must not cause the pain during that examination. Cover her with antibiotics, take high vaginal swab, or send her to GP, gynecologist, to evaluate further type of infection and treat her. A second question, adenomyosis, we do see endometriosis more and more. We do see endometriosis with a 15, 16 years old nulliparous girls, including a large endometriomas. Adenomyosis is more rare. I would say that probably once a year in our setting, in my setting, I would see adenomyosis with nulliparous patient, but that patient is usually beyond the age of 20. So I do not see adenomyosis at the age of 16 so far, but I do see endometriomas, including large endometriomas. In the Center for Endometriosis, where I spent quite a number of years in Johannesburg, in Park Lane, we used to see adenomyosis in nulliparous women under the age of 20, but I would say the percentage was very, very low. I can't give you offhand. I would have to look into the research that was done there, but probably less than 3%.
Thank you, Dr. Dragana, for those answers. Makondo Paul can come through, then Sydney.
Thank you so much for the presentation, Dr. Verenga. I can admit that that's a powerful one, and it's a revolutionary message that you are sending all over Africa. I just want to make a comment on the TVS. Also, like in my plaques, my little plaque, so to say, I think I haven't seen any resistance from women to perform transvaginal ultrasound or to get a consent. As long as you clearly state the reason why you're performing that examination, women, they always come to accept and allow it. The problem, if you don't know why you are trying to do it, the results you are trying to get, why you are prioritizing that one from the other probes, that's where the challenge may come. But if you plainly explain to the client, we have had no resistance, actually. So personally, I feel sometimes that if I haven't proceeded with 2 years for a gyne case, I feel good that there's something little I'm missing, and that little detail makes a very big difference in management and diagnosis itself. So I would suggest that we adopt transvaginal ultrasound as Africa, as long as in our department. I like what usually Chitumba says. He says, Africa, now is our time. So we can get to the standard if we move with time. And the time simply says we need to use transvaginal ultrasound optimally for us to get the desired results and to enhance both the management and the diagnostic aspect of our continent. Thank you so much for the presentation, and thanks so much for enlightening from the Sejon.
Thank you so much for those remarks. Nua Heresa, you can proceed, or is it taken it up? Because I can see the mic is not on. Any other burning questions or comments before we bring the meeting to an end? Okay, I think Mr. Chitumba's question has come on the chat. He's saying he has bad network. Let me just go through his question. He wants to thank our presenter for adding the voice to the intellectual debate on adenomyosis. And he has added the sliding sign to his dictionary of knowledge. He's saying we need to create a bypass to you to have more presentations. Doc, I think we will definitely be coming to knock on your door so that you present more, especially in your area of passion, which is fetal sonography. So we'll definitely be calling you back to present to our African audience.
Maya?
Yes, David?
Yeah, I think, yeah, just a question, I think both to Dr. Dragan and Dr. Verenga. I know our focus has been mainly on endometriosis, I mean, in as far as ultrasound is concerned, but I wanted to know from their practice, what has their experience been in terms of cases of ectopic endometrial tissue, maybe in the lungs, liver, and the brain, because I remember about 8 years ago, we had a patient sent for CT brain because the concern was a possible ectopic endometrial tissue in the brain, because the patient was having a lead lag like on a monthly basis. So I wanted to know from the experiences, how common are other sites in terms of, you know, ectopic endometrial tissue?
Okay, over to our experts.
Dr. Dragana may come through.
Our experience with thoracic endometriosis is actually very high. And it went for a long time greatly misdiagnosed, whereby thoracic surgeons would aspirate the so-called tumor from the pleura, and then endometrial tissue would show up on histopathology, and everyone was scratching their heads, and then they end up with gynecologists. What are you doing with these women? How do you disseminate endometrial tissue, and the woman didn't have a previous surgery? So there were a lot of wandering around for quite some time. Currently, we have a very good experience. The diagnoses are being made promptly, but unfortunately, I still think we spend a fortune to diagnose these lesions, and each time it ends up with these MRIs, which I mentioned the price of MRI. CT scan is substantially cheaper, so we have a high percentage of these patients with a pleural endometriosis, and most of the cases are sorted surgically with aspiration, not a complete excision, and then with GnRH with hormones. Far distant endometriotic dissemination, I just mentioned in a previous discussion. So it's a bladder, sigmoid, rectum, and the deep pelvic dissemination of endometriosis, particularly on the ischial nerve. And it's super painful, and the patients are in agony. For the further distance to pleura endometriosis, I haven't come across in Zimbabwe so far. I didn't experience the case, but I do believe that it's possible. I didn't come across the case further to pleura.
Thank you so much, Dr. Dragana. Mohammed, please, may you mute your microphone? It's giving us feedback since you are not contributing at the moment. There's another question from the chat, which is saying, from the presenter's experience, what is the prevalence rate of adenomyosis in the African or Black population?
It is not known because of the underdiagnosis. Like we say that there is a lot of underdiagnosis in Africa because of the mode of examination that is applied to most of the women who go to for sonography with pelvic symptoms. So it is not known, not only in Africa, but globally because of this. And also the lack of non-standardization in the reporting makes it difficult to know the actual prevalence of the condition.
Thank you for that response. Do we have any other burning? Thank you for the wonderful presentation. What is the age group from, or I think they wanted to say prone to endometriosis? I think this has been answered, that at any age, even from 15, 16, going onwards, I think it's a common, it's now proving to be a common pathology, but the issue comes to underdiagnosis. So possibly most of us could possibly have come across endometriosis, but because of the mode of scanning, mostly I can confess that most of our radiographers and sonographers merely scan gynecological cases using the transabdominal approach. And I think today it's a huge lesson that we need to upgrade our equipment or actually persuade